You unlock this door with the key of compassion. Beyond it is another world, a world of science, a world of common sense, a world of sanity. You're moving into a land of both empathy and ethics, of nutritional knowledge and empowerment. You've just crossed over into Dr. Osborne's zone. Hey, welcome back to Dr. Osborne's Zone. Today we're doing a deep dive on vitamin B1, otherwise known as thiamine. Now this vitamin can mimic, a deficiency in this vitamin can mimic an awful lot of medical conditions and diseases, so I think it's imperative that you understand more about it. First things first, what is thiamine? It's a B vitamin, vitamin B1. Now, it's an essential nutrient, meaning that your body cannot function without it. You will die. In essence, death occurs if you're deficient long enough. As a matter of fact, there's a disease state, oftentimes referred to as beriberi, that ensues the longer you have inadequate thiamine consumption in your diet. So the functions that thiamine helps your body perform are essential for your survival and for your life. If we sum them up, a big part of these functions are that they help the body turn food into energy. Now that sounds like a pretty simple thing, but in reality, it gets pretty complex biochemically, and so let's break some of these elements down for you. Functions of vitamin B1, we've got supporting the heart, the nervous system, as well as the brain. It's important in the production of something called ATP, which equates to energy. When we think of ATP in our body, think of energy, think of the way you think of money in the real world. You need money to pay rent, you need money to buy your food and your clothes and your shelter, etc. Well, your body needs ATP. Think of ATP as your body's money, and you can't make it without vitamin B1. Now, vitamin B1 also supports many functions to include muscle contractility or muscle contractions and the movement of signals from the brain. So there's this neurochemical that thiamine or vitamin B1 helps you to produce called acetylcholine. And this neurotransmitter or neurochemical plays a major role in controlling many of the aspects of what's called our parasympathetic nervous system. And if we look at that here, let's blow some of these images up for you so you can have better understanding of what that means. Many of you have heard of the parasympathetic nervous system and may have a general understanding of it. Parasympathetic nervous system is that part of your nervous system that regulates and controls your healing, your repairing, your sleeping, your digestion, your sexual functions. Think of it as any function that you do where you're not in a state of chronic fear or fight or flight. So there's two parts of your nervous system, what's called the parasympathetic here and then the parasympathetic over here. And again, parasympathetic is what acetylcholine predominantly helps to function. So if you look at all the organs that your parasympathetic nervous system helps to control, you have the eye and numerous glands like your thyroid gland, your pancreas, etc., your heart, your lung tissue, your GI tract. It helps your GI tract to mobilize, to digest your food and to move, your ureters for urination, or rather for filtration, your colon as well, again, part of your bowels and your bowel movement, your urinary tract, your bladder for urination, your genitals for sexual activity, etc. So all these functions controlled by the parasympathetic nervous system are under the control of acetylcholine, which you cannot produce without vitamin B1. And if you want to dive deeper into some of these functions, if you look over here at this secondary diagram, you see here parasympathetic division. It helps the eye. What does it help the eye do? Well, one of the things it helps the eye do is it helps the pupils to constrict, to cut out, or to shave off light. This is so we can get primed for sleep. If our pupils are dilated, we're trying to go to sleep, we're letting too much light in, it's going to be harder to signify or to signal sleep messages to the deep brain. So part of this control is it helps your eye muscles shrink your pupil. We also know that it plays a role in the lacrimal glands. Well, what are the lacrimal glands? They're your tear ducts, and so it's how we cleanse the eye. It's how we wipe out debris. If you get dirt or other debris in your eye, the lacrimal glands help to produce tears, and very important job in that regard. Now, we also have functionality here in what are called the submandibular and the parotid glands. These are the glands in your mouth that produce saliva and digestive enzymes. So, many of you have something called Sjogren's, which is an autoimmune condition where it leads to dry eyes, dry mouth, because there's an autoimmune reaction against these glands. Again, acetylcholine produced by vitamin B1 helps these organs do their job, helps these tissues do their job. And so sometimes what happens is somebody will go to the doctor, for example, they'll get a diagnosis of Sjogren's because they have dry eyes and dry mouth. The doctor doesn't measure for vitamin B1 deficiency, mistakenly diagnoses them with Sjogren's disease, but in reality, a little bit of vitamin B1 and you're on your way. So if you struggle with dry eyes and dry mouth and don't know why, and your doctor's not been super helpful, you may consider something like vitamin B1 to see if it helps. Now, we also have regulation of the heart. You can see here it slows the impulse and the conduction, and it can decrease the heart rate. So what happens when your vitamin B1 levels are low? One of the side effects is something called congestive heart failure, CHF. It can cause your heart to enlarge, and it can cause congestive heart failure, and that can lead to swelling of your extremities. And so swelling in your feet, swelling in your hands, etc. We know it can affect the lungs, and so it helps with the mucus secretions of the lungs. So it helps keep your lungs lubricated. It also helps with the musculature, helps the muscles in the lungs contract so that you can breathe more readily and get more oxygen through that breathing. You can see here for the stomach and the intestine, it regulates the tone, it regulates the sphincters, which are the areas, the little gated areas along the intestinal tract, and it helps with secretions of fluids. Again, going back to digestion and mucus secretion to protect you from things like leaky gut. It also helps with the contraction of the gallbladder. Remember, the gallbladder secretes bile. That bile is very important for your ability to digest and absorb fat. So if you don't have vitamin B1, these are all things that potentially could be affected as a result of that acetylcholine deficit occurring from deficiency. We also know it helps the liver in glycogenesis. It helps the pancreas both in the production of insulin, but also in the production of enzymes to digest with, so your digestive enzymes. Pancreas also produces something called bicarbonate, which neutralizes stomach acid, so very important function in that regard. We know it helps with contraction of the ureters so that you can go to the bathroom appropriately. It helps with tone, secretion, and sphincter muscles in your colon. It helps the sphincter muscles and the muscles of the bladder. It helps with erection and vasodilation in the genitals. So for your sex performance, you need vitamin B1. So a lot of different potential outreach from this one chemical over here that requires vitamin B1 for its production. So all that being said, let's pull up another diagram. And I want to just give proper recognition to the authors of this diagram. This is a really great book. We'll hold that up for you. But Thiamine Deficiency Disease, Dysautonomia, and High-Calorie Malnutrition. This is a great book by Derek Lonsdale and Chandler Mars, two doctors who are really experts in this arena. And so they've done a really great job of helping to kind of put into a picture where vitamin B1 plays a function biochemically. And so I want to point that out. You can see here, vitamin B1, highlighted here, helps to convert this chemical right here, which is a derivative of glucose. So when you eat food, that food's broken down. Part of that breakdown is into pyruvate. Vitamin B1 helps you convert that chemical into this substance here called acetyl-CoA, which is a precursor to making acetylcholine, which is what we just finished talking about. That acetylcholine is the primary neurotransmitter that regulates your parasympathetic nervous system. That's the part of your nervous system that helps you heal, repair, digest, sleep, have sex, etc. So very, very important function. Now we also come down here and we can see some of the other places where, chemically speaking, vitamin B1 works. It works in the conversion of a chemical called alpha-ketoglutarate into another chemical called succinyl-CoA. Why is this important? This goes back to what we were talking about a moment ago. ATP, or energy production. Vitamin B1 is essential for helping your body convert food into energy. This is also known as the citric acid or Krebs cycle, which is one of the main cycles that helps with that. Many of the steps in the cycle are dependent upon vitamin B1. We also know that vitamin B1 helps to take your branched chain amino acids like isoleucine and valine and help to convert them into succinyl-CoA, which is another substrate that helps your body generate ATP. So very important. Maybe that's heavily in biochemistry, maybe too much for some of you, but I want you to understand, in general speaking, you can't make acetylcholine without vitamin B1, and you can't convert your food into ATP or energy without adequate vitamin B1. And this is one of the reasons why a deficiency of this nutrient comes with so many different types of problems. And we'll talk about those here in just a minute. First, I want to go into thiamine deficiency. Who's at risk? And we talk about, if you ask your doctor, do I have a thiamine deficiency and can you test me for thiamine? The common answer you're going to hear is thiamine deficiency, that's nonsense. That doesn't happen anymore. That's only in third world countries. That's only in impoverished places of the world, or that's only in people who are wasting away or malnourished. And the reality is, thiamine deficiency is extremely common even in the United States. Let's break down why. Let's break down who's at risk. You see this also, the same research review paper taken from the same doctors who wrote the book I mentioned earlier, Chandler Mars and Derek Lonsdale. You can see here, hiding in plain sight, modern thiamine deficiency. We've got, with an average diet, even a poor one, it is not difficult to meet the daily requirement for thiamine, and yet measurable thiamine deficiency has been observed across multiple patient populations with incidence rates ranging from 20 to over 90% depending on the study. This suggests that the RDA requirement may be insufficient to meet the demands of modern living. I think it's important for that connotation, modern living, because a lot of people are deficient, not so much because they can't access thiamine from foods that they might eat. They're deficient because of their lifestyles. Let's take a couple of examples here. People who are obese. You see, there's a high degree of thiamine deficiency in obese individuals. Here, the rate of deficiency ranges from 15 to 29% when tested prior to bariatric surgery. So in the studies that they're citing here, patients that were morbidly obese going in to have bariatric surgery or stomach stapling or bypass, when they measured them going in pre-surgically, thiamine deficiency was present in 15 to 29% depending on measurement. You can see here after surgery, the rate of thiamine deficiency climbs, and with it, an increasing risk of something called Wernicke's encephalopathy, which is a neurological damage that's caused as a result of thiamine deficiency. So first it's important to understand that people going in for bariatric surgery are obese. That's why they're going in. Many of them, up to a third, are deficient in thiamine, and the deficiency progressively worsens after the surgery because when you bypass the stomach, you're affecting digestion and absorption. You're affecting digestion and absorption of thiamine. And you can see here 42% of the U.S. population was considered obese, and this is a statistic from 2018. That number is actually higher today. And 39% of the adult population worldwide is considered overweight or obese. So we're talking about the mechanism of just the fact of somebody being overweight or obese and being more at risk for thiamine deficiency. If you come down here and look at diabetes, for individuals with type 1 or 2, so whether you have type 1 or type 2 diabetes, plasma thiamine was estimated to be approximately 76% lower than in non-diabetic controls. That's a tremendous difference. And so we ask why. Why do diabetics have such lower levels of thiamine than non-diabetics? You can see here in another study, frank deficiency was found in 98% of the study population using plasma and urine samples. They go on to say the mechanisms involved in hyperglycemia are two high blood sugar driven impaired uptake in the kidneys. So there's an impaired uptake of thiamine along with an increased clearance. But there's a few other things that I think that are important to bring up here with diabetics and the diabetic population. And one of them has to do with medication use. Now, diabetics commonly get put on a drug called Metformin. And recent research studies show that Metformin blocks vitamin B1 uptake in the intestines. So if you're diabetic, we see diabetic levels much lower than non-diabetic levels. It's very potentially possible beyond just the high blood sugar creating a problem with uptake. Metformin, the drug used to treat diabetes, blocks the uptake into your intestines or from your intestines into your bloodstream. So we also know in the same kind of realm of ideas, understand that high carbohydrate diets play a major role here. As you can see, perhaps the most commonly disregarded factor when considering thiamine status is the consumption of the individual's diet. High carbohydrate diets effectively decrease circulating thiamine concentrations by a number of mechanisms. So not just one way, but many ways. You see here, metabolizing carbohydrates regardless of their source or quality. So, we make this claim it could be even a good carbohydrate, a piece of fruit or vegetables, regardless of their source. Very important to make that distinction. Carbohydrate overconsumption diminishes thiamine stores in the body. One study found that when 55% of total caloric intake came from carbs, no matter their source, again, it doesn't matter what kind of carbs, thiamine status in otherwise healthy and thiamine sufficient individuals declined. Now, I've talked about this often where, the question comes up a lot, well, what should I eat and how should I eat? I've talked about this rule of thirds. Nature generally presents itself with balance, not with imbalance. And so I think part of the problem in our society, especially in the US, is we try to solve imbalance with more imbalance. So like an example of this would be we try to solve diabetic diets with ketogenic diets. So patients eating carbohydrates, 70% of their total calories coming from carbs. The antidote becomes a ketogenic diet where they're not eating where they're eating hardly any carbs, right? And so they bounce from one imbalanced diet to another imbalanced diet. But this is why I like to start people with the presumption of balance. Carbs, fats, and protein. A third, a third, a third, give or take. Again, in this, you can see in this review, research has shown that when your carbohydrate level goes over 55% of your total caloric intake, no matter the source of the carb, the thiamine status will actually decline. As carbohydrate intake increased, thiamine decreased further. In contrast, lower carbohydrate or higher fat diet slows thiamine loss in thiamine restricted experimental conditions. So while protein seems to preserve thiamine. So what do we see in the modern American diet? And this is one of the reasons why I think this is such a prevalent deficiency. I see this deficiency probably 20-30% of the patients that I see in my practice, because the average American diet is 70+% carbs. And it's typically low protein and high fat. And the fat that's being consumed is predominantly seed oils. And so from processed mechanisms. And so you have this super high inflammatory seed oil diet providing massive amounts of omega-6. You have an abundance of carbohydrates. Again, this is definitely going to deplete not even just vitamin B1, it depletes all of your B vitamins because they're required for your, anytime you increase your carbohydrate load, you have to understand carbohydrates put demand on the status of B vitamins because you need B vitamins to metabolize the carbohydrates, to break them down into their smaller parts so that your body can convert them into energy. So if you're eating a this is especially true of a highly processed carbohydrate diet, where heavy carbs are going to deplete your B vitamin status, when you couple that with a higher fat load with excessive seed oils that create an omega-6-3 imbalance that leads to heightened levels of inflammation, and low protein. Protein preserves, as we said in the study, protein preserves the degradation of thiamine. So we want balance. You don't need to be 90% protein either. Don't think that just because protein, because it preserves it, that you need to go crazy in that direction. Don't solve imbalance with more imbalance. Try to come back to balance. But at any rate, I want you to understand high carbohydrate diets definitely have an impact on thiamine status. And so when we ask the question about diabetics, right, we just said that diabetics, for individuals with type 1 or type 2 diabetes, 76% lower vitamin B1 levels than in non-diabetics. And this is part of the reason why is that excessive carbohydrate intake, because we know that excessive carbohydrate intake contributes to the development of diabetes. And so these things play together. Now, there are other things in our world that will contribute to thiamine deficiency as well. I think it's equally important to understand. And one of those is food chemicals. In addition to the carbohydrate load, processed food tends to carry a much higher toxicant load than unprocessed and organic foods. Every aspect of commercial food production involves the usage of chemical products that are toxic to the mitochondria. This is where your energy is made inside your cells. Many of these chemicals used in commercial agriculture through the various channels of processing, preservation, and presentation degrade thiamine and other nutrients when consumed. So, this is why we talk about trying to eat whole, real foods that aren't processed, that are in season, that are grown without pesticides and other chemicals, because thiamine is relatively abundant in a healthy diet. It's when you start going the direction of processing and excessive chemical exposure. We also know that alcohol, tobacco, coffee, and tea consumption will impact or affect thiamine status. While chronic alcoholism is a recognized contributor to thiamine deficiency in the form of Wernicke-Korsakoff syndrome, the role of regular alcohol consumption below the threshold of alcoholism. So if you're that person that drinks a glass of wine a night, this is what we're talking about. The role of thiamine depletion below the threshold of alcoholism is underappreciated. Regardless of the amount, the ethanol in alcohol, I think it's important to highlight this, regardless of the amount, the ethanol in alcohol blocks conversion of dietary thiamine into active thiamine. So when you eat thiamine from your food, your body has to convert that thiamine, has to activate it. And alcohol, ethanol, blocks that conversion, reducing thiamine availability by as much as half, 54%. So that glass of wine every night, you're blocking it every night. Is it simply a matter of degree relative to chronicity that determines the rate of thiamine depletion? When consumed regularly, alcohol damages the intestinal mucosa. This is another aspect. So when you damage the intestinal mucosa, you result in impaired absorption and dysbiosis. Now, part of what we're learning is about dysbiosis is that when you have an imbalanced microbiome, one of the important components to the microbiome, so these are the bacteria that live in your GI tract, but the microbiome helps make B vitamins. And so as we learn more about that role of these bacteria, it's important to understand that anything you can do to preserve the integrity of your microbiome has to be a priority in your health. And so alcohol consumption impairs not only the absorption through damage to the intestine, but also contributes to dysbiosis in the microbiome. We also know nicotine in tobacco products inhibits thiamine availability by antagonizing the thiamine transporter in the pancreatic cells. We were talking earlier about the role that vitamin B1 stimulates the pancreas and helps it produce enzymes and insulin. But here you can see nicotine inhibits uptake of thiamine by these cells by greater than 40%, and possibly in other tissues as well. This impairs insulin secretion. So when you think about it, you're drinking and you're smoking, you throw a high carbohydrate diet into that mix. It's like a perfect storm for inhibiting thiamine uptake and a perfect storm for pancreatic damage. We also know that caffeic acid, chlorogenic acid, and tannic acid, these are substances found in coffee and tea, as well as energy drinks, for those of you who don't do coffee and tea and think those energy drinks are great. We know that these chemicals oxidize the thiazole ring of the thiamine molecule, impairing its absorption. So drinking heavy amounts of coffee or tea or energy drinks will impair thiamine uptake. And then you add that, most people don't just drink coffee plain or tea plain. Energy drinks are loaded with sugars and other chemicals. But you can see, while the added sugars, flavors, and other substances to enhance taste increase thiamine demand. And they go on to say 62% of Americans consume an average of 3 cups of coffee per day. So, are you one of those? Is that what you're doing? Are you eating a high carbohydrate diet, drinking excessive quantities of coffee, where you're impairing your body's ability not only to absorb thiamine, but you're depleting and overutilizing or burning through your thiamine, and so you're at risk. And again, this is a pretty common scenario. Let's talk about one other area that is very common today, and that area is called polypharmacy. So medications is what we're referring to. You can see here, after the diet, the next most common threat to thiamine sufficiency is the use of pharmaceuticals. Pharmaceuticals deplete thiamine and other nutrients directly and indirectly by a number of mechanisms. Some of this is by design, as with certain antibiotics that target thiamine, and some of it represents off-target effects, such as the blockade of thiamine transporters. As we mentioned earlier, thiamine transporters are blocked by metformin. And the 146 other drugs that have tested for this action, there was a recent paper published on mechanisms of many, many different classes of drugs creating an inhibition of thiamine transporters, and so basically blocking their ability for the intestinal cells to uptake thiamine. We also see among the greatest threats to thiamine status metformin, psychiatric medications, which are very common in today's world, metronidazole, which is a common antibiotic and antiparasitic, used especially if you've been to out of the country and you suspect you've picked up a parasite. A lot of doctors prescribe that drug as an antiparasitic, as well as other antibiotics and hypertensives, or hypertensives. You see that also pain medications, non-steroidal anti-inflammatory drugs, acetaminophen, and aspirin. As well, we've got proton pump inhibitors. How many of you have ever taken an antacid, drugs that block stomach acid? We also know that diuretics and chemotherapeutic drugs, so cancer treatment drugs, all can contribute to thiamine deficiency. They go on to say, it should be noted that chronic polypharmacy has become normalized in recent decades. In other words, it's normal for a person to be on 5, 6, 7, 8, 9, 10. I've seen people on more than 20 medications at a time. That's the standard. As a matter of fact, several patients I've seen over the years will come in, and these be people in their 70s, and they'll say, I went to my other doctor, and when they asked me what medicines I was on, I said, I'm not on any. And their doctors just can't believe they're not on medicine. I've even seen people in their 50s where their doctors are like, what do you mean you're not on medicine? You should be on some medicines. It's like, why should we be on medicines? What's the purpose? What's the point if we do it right? So chronic polypharmacy's become normalized in recent decades, even though it's, it really is an indicator of terrible health. And so the additive effects of these drugs on micronutrient depletion is likely significant. So drug-induced nutritional deficiencies, which we've talked about on numerous occasions as it relates to multiple mechanisms. So going back to causes of B1 deficiency, we mentioned alcohol, tea, coffee, energy drinks. Caffeine can do it as well. Seizure medications, diuretics used to lower blood pressure. So if you're on Lasix or furosemide or hydrochlorothiazide, these are all drugs that that deplete water to lower blood pressure, have a tremendous impact on thiamine status. As a matter of fact, hydrochlorothiazide, oftentimes abbreviated as HCTZ, it reduces thiamine uptake into cardiac cells, into your heart cells. This is one of the mechanisms of congestive heart failure. Been a number of studies where doctors have looked at patients in hospitals in hospitals because of congestive heart failure who were taking multiple types of diuretics, and they found high proliferation, or not proliferation, a high prevalence of thiamine deficiency in these patients, and that when you supplement them with thiamine, in many cases their congestive heart failure improves. What's called their ejection fraction improves. You see a thiamine deficiency in congestive heart failure, patients receiving long-term furosemide. This is a diuretic. Furosemide therapy is a type of diuretic for blood pressure. And you can see here biochemical evidence of severe thiamine deficiency was found in 98%. This was a 24 out of 25 patients being studied when they were receiving 80 milligrams a day of furosemide. So look at your dose. If you're on furosemide, look at your medicine, look at your dose. If you're on 80, taking thiamine, vitamin B1, probably a pretty good idea for you. Even better yet, go ask your doctor to measure your thiamine status. And we'll talk more about how you can measure and what tests you can ask for to get thiamine measured here shortly. So we know the drugs cause the depletion. Here's another case in the elderly, diuretic use. A risk for subclinical thiamine deficiency in elderly patients. Vitamin B1 nurture worsened during the hospitalization, and in a multivariate procedure, the only significant predictor of the change in the vitamin B1 nurture was the use of diuretics. So in the hospital, when they were pumping people full of these diuretics, their vitamin B1 status deteriorated, and they were able to prove that definitively with a p-value of less than 0.001, which is phenomenally, we'll just say it's extremely accurate. When you have a p-value of anything really less than 0.05, it means that the likelihood that there's causation is extremely high. So the changes in the ETK, erythrocyte transketolase activity in whole blood, this is one of the tests. ETK is one of the tests you can ask for, sometimes referred to as ETKA. So it's erythrocyte transketolase activity coefficient is what that refers to. And so it's a test that measures for the functionality of a particular thiamine-dependent or vitamin B1-dependent enzyme. And so this ETK activity or coefficient during the hospital stay was one of the things they were assessing thiamine status with. So in this case, our data suggests that hospitalized elderly at an increased risk, again, as you're hospitalized elderly, increased risk for vitamin B1 deficiency, especially when on diuretic treatments. So if you've been hospitalized and been pumped full of diuretics, you should be asking for thiamine as well. It's very well documented. I've just shown you a couple of studies, but this has been documented for decades. This is something we've known about for a very long time. And you should demand better care. If you're being loaded up with diuretics, you definitely want to consider vitamin B1 to offset that if a diuretic is something that you absolutely have to take. You see the conclusion here, thiamine supplementation prevent the development of subclinical wet beriberi in older subjects on diuretics. What is wet beriberi? Wet beriberi is congestive heart failure in disguise. In other words, a lot of times these patients, they have a history of cardiovascular risks, and so the doctors assume that when they develop congestive heart failure, the doctors just, it's heart disease, you have heart disease. They make no notion or notation about the fact that you might have developed this heart disease as a result of decades of diuretic use, causing your vitamin B1 status to deplete to such a great degree that your heart is no longer to produce energy adequately and pump effectively, and so it's failing. Vitamin B1 deficiency can cause that, so be aware. It's a mimicker. Vitamin B1 deficiency can cause a lot of different kinds of diseases that doctors dismiss and don't associate with the vitamin B1. And this last one, I've talked about this a few times, metformin is a substrate inhibitor of the human thiamine transporter. So it blocks it. Then if you look at this diagram over here, you've got the human thiamine transporter here inside of an intestinal cell, and what happens is you got thiamine trying to come in, and you got metformin blocking that from occurring. And so this is in your intestines, folks. So this is you think about it as this is the lumen or the tube of your intestine. This is one side over here. This is the side over here. So imagine, if we draw this out, it forms the tube of the intestine. And so food's coming through, right? You're taking the drug blocks the uptake by these cells to get that thiamine across. And so remember, your blood's on the other side. How do you get that B1 into your blood? If it's being blocked by the drug you're taking to control your blood sugar. And remember that B1 is necessary to help you take blood sugar, glucose, and convert it into energy. And so if you're taking a drug because your glucose is too high, you're taking a drug to improve your glucose utilization, and you're blocking vitamin B1, and you can't get energy from the glucose that you're consuming, and you get stuck, and that's when you get tired. But we also know that one of the side effects in diabetics chronically suffer with or develop neuropathy. And neuropathy oftentimes is blamed on the diabetes. We say sugar neuropathy. The glucose elevations trigger the neuropathy. But is it the glucose causing the damage to the nerves, or is it the vitamin B1 deficiency that's occurring? Because you need vitamin B1 for the nerves to function. Vitamin B1 deficiency, one of the known side effects is neuropathy, polyneuropathy. So metformin blocks uptake of this vitamin. Metformin also blocks, and it's important to say, it blocks vitamin B12, it blocks folate, and it blocks CoQ10. And these three other nutrients can also, when these are deficient, can also contribute to neuropathy. So you've got B1 deficiency, B12, folate, CoQ10 deficiency, all can be induced by metformin as a medication. It's one of the reasons I'm not a big fan. There's so many doctors out there, especially on YouTube, talking about metformin as a longevity drug. It's like, take metformin on purpose to supposedly improve your lifespan, but it's depleting these very critical nutrients that can lead to a multitude of different types of problems and side effects. Okay, so what are some of the common symptoms? How do you know, when do you suspect you might have a vitamin B1 deficiency? Well, these are some of the more common symptoms. You can see fatigue, muscle pain, anxiety. We also see things like OCD and ADD because of the effect on acetylcholine, that neurotransmitter we were talking about. The acetylcholine is the primary chemical in your brain that allows your brain cells to communicate properly. So all kinds of mental dysfunction can occur. As I've just mentioned, neuropathy is a common side effect of vitamin B1 deficiency. We know that vitamin B1 deficiency can also cause high blood pressure. And we said earlier, beriberi, which is basically a form of heart disease that manifests as congestive heart failure. So high blood pressure, congestive heart failure, both affecting the impact of your heart. And if we come over here, increased heart rate or elevated rate, a lot of people, they go to the doctor, they've had high blood pressure, increased heart rate, and their doctor says quit exercising, which one of the best things you can do for high blood pressure and increased heart rate is to go and exercise. Exercise also improves uptake of thiamine. It improves absorption as well, but also cellular uptake from your heart and from your muscle tissue. We got brain fog can occur. Brain fog, memory decline. There's actually some research now looking at thiamine as it is associated with Alzheimer's disease and other forms of neurological disease like Lou Gehrig's or ALS and Parkinson's disease. So affects the mind. We know that it also can contribute to depression. So these are pretty common symptoms that people have, right? If you look at across the board at statistics medically, how many people every year go to the doctor for these various different reasons? It's very common. This represents millions of individuals. Now, you go to the doctor and you have these different types of symptoms. How many of you have ever had a doctor measure your vitamin B1 levels to make sure that you're not B1 deficient and that that's not the driving factor behind this? Especially those of you that are high coffee consumers, smokers, are overweight, have pre-existing diabetes, those of you that have a high carbohydrate diet. I mean, this should be the standard of care. In essence, doctors should be measuring for vitamin B1 deficiency as a standard of care for these types of situations and conditions. Here's something that I think was brilliantly stated. This was a clinical report on thiamine published in the Annals of New York Academy of Sciences. Thiamine is an essential water-soluble vitamin that plays an important role in energy metabolism. As we've mentioned before, thiamine deficiency presents many challenges to clinicians. I think it's important to note that. Why does it challenge clinicians? In part, it's due to the broad clinical spectrum referred to as thiamine deficiency disorders, TDDs, affecting the metabolic, neurologic, cardiovascular, respiratory, gastrointestinal, and musculoskeletal systems, concurrent illnesses and overlapping signs and symptoms with other disorders. So important, overlapping signs and symptoms with other disorders can further complicate this because, again, you go to the doctor, you may have these conditions, but doctors aren't measuring for thiamine deficiency disorders. As such, thiamine deficiency disorders are frequently misdiagnosed and treatment opportunities missed with fatal. Let's just think about that for a minute. Fatal. What does that mean? Deadly. Fatal. So no joke, right? Fatal consequences, or if it doesn't kill you, potentially creates permanent neurological consequences or sequelae. Nerve damage. Any of you have ever had a painful neuropathy, you know what I'm talking about. So nerve damage is extremely disruptive of quality of life, but fatal is the key word there. So you've got multiple overlays where thiamine deficiency can cause dysfunction in many ways that are commonly diagnosed incorrectly because doctors aren't measuring for thiamine deficiency. And if we look at this diagram, do I need meds or do I have a B1 deficiency? And if we look at some of the basic functions, so thiamine status, if we have normal thiamine status, we're okay. But if we have deficient, if our thiamine status is low, one of the side effects is a reduction in acetylcholine, which I've mentioned. We talked about this in depth. And so when acetylcholine is low, some of the side effects that can occur: memory loss, depression, irritability, congestive heart failure, edema, nerve damage, right? And so what commonly happens? You go in with memory loss, depression, or irritability. What does your doctor do? He says, let's do antidepressants. In many cases, that's the treatment. And unfortunately, what do many antidepressants do? Antidepressants contribute to thiamine deficiency. This is one of the classes of medications that we know can impact your thiamine. We know that with acetylcholine reduction, we can get nerve damage. And with nerve pain and nerve damage, one of the hallmark drugs prescribed in today's medical world is gabapentin. Well, what does gabapentin do? Gabapentin reduces GI motility. This is also one of the symptoms of thiamine deficiency. So now when we have altered gut motility and we're creating constipation, it's leading to malnutrition. But it's also leading to toxic buildup in the intestines. And if you have leaky gut, now your poop starts leaking into your bloodstream and potentiates a systemic inflammation. The gabapentin doesn't fix a thiamine deficiency. It just artificially manipulates the way that you feel, so it doesn't solve the problem. Same thing here with edema and congestive heart failure. Generally speaking, what's prescribed? Blood pressure medications. Well, if you get put on another diuretic, we already showed you earlier, diuretics directly deplete thiamine. So, you're chasing it. More thiamine deficiency, which leads back up to more acetylcholine deficiency, which further exacerbates the problem. So in essence, the treatment for the problem leads to the thing that actually caused the problem, because the doctors aren't looking for what causes the problem. We come over here to this side. We know that thiamine depletion can increase blood lactate, pyruvate levels become problematic. That can lead to muscle pain and fatigue. It can also emulate the symptoms of chronic fatigue syndrome. So muscle pain, muscle fatigue. You go to the doctor, or you go to the pharmacy. You pop some ibuprofen or Tylenol. What did we say earlier? That two of the classes of medications that we know deplete thiamine: non-steroidal anti-inflammatories and acetaminophen. So we're feeding into the deficiency. Chronic fatigue syndrome, most people get kind of pigeonholed into, this antidepressant diagnosis, and they get put on antidepressants, and again, depleting their thiamine status even further. The takeaway here is thiamine mimics a lot of different clinical conditions. If doctors aren't aware of that mimicry and they just completely ignore doing any kind of testing to eliminate the possibility that you could have a vitamin B1 deficiency, then your window of opportunity to figure out why you have the problem goes away, and the medicine can actually contribute to worsening the very problem that's there, which in this case is a vitamin B1 deficiency. Okay, let's talk about food sources. How do we get vitamin B1 in our diet? As we mentioned earlier, protein spares it, excessive carbohydrates depletes it. So keep those two things in mind as you're choosing your foods. But if we're talking pound for pound, highest source is pork. Now, many of you don't eat pork, and that's fine. You can get it from beef. You can get it from organ meats. If you're trying to get it from plant-based foods, spinach, almonds, and peas are also options for you as well. These are high food sources of thiamine. So all good options. Now, there's also the potential that you might want to supplement. And I would say if you're on multi-medications, if you've got a polypharmacy situation going on, in my opinion, the best thing that you can do really is to test for deficiencies. So I want to do testing. You can also supplement, so we'll talk about that too. So we'll talk, those are food sources, but let's talk about testing. There's different labs that you can ask for to do testing. One is the erythrocyte transketolase activity coefficient, or ETK is the abbreviation for that. This is probably from a perspective of medical testing that most doctors would have access to, this is one of the better tests. So I'm putting it as number one, because if you have insurance and you're talking to your GP or your main doctor, they should be able to look this up in their battery of tests, and they should be able to run this. It's not a matter of whether they can, it's a matter of whether they're willing to. But it is a test that insurance would cover if you asked for it. There's also serum, which I'll put last. There's urine and serum tests. Not as accurate. Don't really recommend them if you're really trying to be super accurate. But if it's the only thing you can get, this is better than nothing, especially if it comes back low. The problem with serum testing is it's reflective of potentially of something called liver redistribution. Your liver can store thiamine in its tissue, and if your body is deficient, if your cells of your heart are deficient, you know, there's a communication between your organs, and if one organ is deficient, there's a message communication where the liver is communicated to. And so what we have is we have the liver will pump out its storage. It's called redistribution. It will take what it has in storage, in this case vitamin B1, and it will pump it into the bloodstream so that it can get to the organs that have the need. And so if I'm going in and today is the day I'm going to visit my doctor and I'm getting a needle and they're drawing my blood today and I'm picking up on that B1 redistribution, then I might have in my serum thiamine value, they may come back and they may look normal. But in fact, I'm dipping into my liver storage to prevent my body from becoming sick or majorly problematic. So you don't want to run serum if it's, you know, unless it's the only option you have. Because of that redistribution component, you can get a false normal, and then your doctor says your levels look fine, don't worry about supplementation, when in fact you could be severely deficient. So ETK, if you can get that test, that's ideal. My favorite test is, so I'm going to put a star here in this, is something called INA, intracellular analysis. And what makes this type of technology and testing different is it's not measuring, it's one of the other problems here is these tests are measuring a level or percentage, not so much the ETK, but the serum and the urine are measuring a level of B1, and then they're comparing your level to others. So if you know what a bell curve is, what generally happens is you take 10,000 samples of people's blood and you calculate the vitamin B1 and you average it, and what we call the mean. And that represents the center of the curve. And so then some calculations are performed where you take what are called standard deviations. Each line represents a standard deviation. So this would be +2 and this would be -2 standard deviations. So anything that falls within 2 standard deviations of the middle, of the mean, is considered normal. This is how lab tests evolve or develop normal ranges. The problem with this is that you're comparing yourself to others. You have your own uniqueness, you have your own biochemistry, but who's included in those samples that calculated the normal ranges? Those are men, those are women, those are people that weigh 300 pounds, those are people that weigh 100 pounds. They're people from all walks and all dynamics of life, and none of them are you. And so you're comparing yourself to people who aren't you, people potentially different genders, heights, weights, sexes, people with different heart sizes, with different vascular links, with again, all kinds of variable possibilities. And so the normal really is just a mathematical equation that doesn't really relate clinically to a health outcome very accurately. So when you're using lab tests that rely on these standard deviation bell curves and normal ranges of what they're calling normal people that they're sampling in the population, how do you know those people that they took samples from were normal? I mean, that's the other part of the equation here, is that what does healthy mean? I think we debate on what that means. So how, if we take 10,000 healthy people, but we're debating on what healthy actually means, how do we know those ranges are actually accurately normal? So I don't care for that type of investigation if I can avoid it. Now, there are times where we use it, but if we have an option, we would ideally prefer, with testing, we would prefer something called a functional outcome. Functional outcome means you're not measuring other people's levels and then comparing yourself to them. You're measuring an outcome of your own cells. And that's what I love about this type of technology, because they're taking your cells, they're stimulating your cells to grow and to function, to replicate, and they're measuring that growth rate. And so your baseline is your own growth rate. It's yours. It doesn't belong to anyone else. You're not comparing your growth rate to other people's growth rate. You're looking at your own growth rate. So this is part one to a test like this. Part one is you assess your own growth rate. What is the growth rate of your cell as it's growing? And part two of the test is you provide the nutrient. In this case, you provide vitamin B1 to the cell. And what changes? If the growth rate doesn't change, if it stays the same, you're not deficient. You're not going to benefit more by giving your cell more of the nutrient. But if your growth rate skyrockets or dramatically improves, then the outcome of how your cells function, this is functional outcomes, the outcome of how your cell function improves. Now you have justification for understanding that, hey, when I give my cells more B1, they work better. And to me, that's a far more accurate way to assess an individual's need compared to comparing you to other people who aren't you based on normal range calculations from people who we're not really sure were quite normal. So that's why I like this technology the best when it comes to assessing really vitamin B1, but any nutrient. And for those of you who are interested in learning more about that type of testing, I'll put a link in the show notes for you, and you can check that out and read more about it. But INA definitely a better way to go about it. So once you've established whether you need thiamine or not, what do you take? So there's different forms of thiamine. So if we're talking about supplementation, if aside from just trying to eat it, because you should try to eat it. You should try to have a reasonable carbohydrate diet, but not overdoing it. You should try to limit any kind of alcohol or excessive caffeine or other things that we know contribute to the deficiency. But if you're going to choose the supplement route, it's important. Vitamin B1 is water soluble, has a short half-life. That means half-life for vitamin B1 is about 12 hours. That means it doesn't take very long for that supplement that you just took to get out of your system really quickly. So, and this is true of all water-soluble vitamins, they need to be taken on a regular basis to be effective. So, water-soluble form of vitamin B1, typically, you'll see thiamine, hydrochloride. This is a really common one that you'll see on a supplement label, and this is a good form. It's not the best form, but it's a good form. It's good quality. It works. And dosing, research studies show dosing structures ranging from, very easily 10 to 100 milligrams being very safe. Now, if you want to go higher than that, more power to you, but I would recommend you work with an expert, if you're really going super high on these, and for prolonged periods of time. And I'd recommend that you get your levels tested regularly and just make sure you're not overdoing it. But 10 to 100 milligrams per day, pretty safe. A lot of research studies showing that those doses are safe. Again, it's a 12-hour half-life, so it comes right out of you. It doesn't accumulate in your tissues. So it's pretty good. Now, one of the things you want to consider when you're supplementing with thiamine is that once it gets into your blood, it's got to be activated. And to do that activation, this requires Magnesium. So we know that a good chunk of folks in the general population are magnesium depleted. If you want to learn more about magnesium, go check out one of my crash courses on magnesium. But magnesium activates thiamine. So it converts it into its active form. And so if you're magnesium deficient, you could actually cause a thiamine deficiency secondarily. In other words, you might have plenty of vitamin B1, but your issue might be magnesium and not vitamin B1. And if you add the magnesium and you activate the B1 you have, you might be back in business. So it's important to understand that relationship. You need magnesium to activate B1. So if while you're asking your doctor to measure your thiamine, also ask them to measure your magnesium. One of the simplest tests that you can ask a doctor to run is called an RBC magnesium level. It's one that, if you ask and they'll do it, your insurance could cover it. Otherwise, one of the better ways to check it is INA, intracellular nutrition analysis. But you can ask your doctor. Serum magnesium levels are a waste of money. Don't waste your time. But RBC magnesium is a pretty decent assessment. INA is even better. But you need magnesium to activate thiamine. So if you're using thiamine in this form, definitely want to consider potentially putting magnesium in the equation, especially if you're getting into these higher doses. I've seen some people trying to take higher doses of vitamin B1, and they start having symptoms like heightened anxiety, nervousness, jitteriness, and when they add in the magnesium, then things kind of calm back down, and it's because that magnesium is necessary to activate it. So just be aware of that association. Now, there's another form of vitamin B1 called benfotiamine. This one's been studied. There are a number of research studies on benfotiamine. I've talked about these in the past for you, but this is it's better absorbed. It's fat soluble, not water soluble. And for certain conditions, especially neuropathy, there's research that shows it actually works better. In doses range, you can get anywhere from 50 to 300 milligrams if you're on your own, but if you're going above that, I really recommend you work with somebody. But something to consider, though, with this is that if you don't have a gallbladder, if you've had your gallbladder removed, cholecystectomy, right? If your gallbladder's gone, this is fat soluble, and so your bile is influenced by missing gallbladder. So will you have reduced absorption of benfotiamine if you're missing your gallbladder? And the answer to that is potentially yes. So you might consider, if you're wanting to use this one, some form of supplemental bile to take. I recommend something called Lipogest as a bile substitute. Again, if you have that as part of your history or part of your problem, just something to consider. So whether it's a fat-soluble benfotiamine, there's also allithiamine, which is a type of thiamine as well. It's harder to come by. There are very few companies that produce it. But these are really very common, and you can find these over the counter quite easily. And both of them are good products. Both of them are good quality supplements, and both of them work really, really well. But I would say, in my experience, nerve damage, benfotiamine, vastly superior. Again, I'm giving you my experience. I want you to understand. You may have had a different experience. Look, everyone's unique in that regard. But thiamine hydrochloride or benfotiamine, both are good options. This one, in my opinion, is better when you have nerve damage. You need bile to absorb it properly. So if your gallbladder is removed, you might want to consider bile acid supplement with this one as well. And actually, with both of them, require magnesium for activation. So you want to make sure that your magnesium stores are not low, so that you can activate that thiamine once it hits into your bloodstream and starts to try to help your cells do their job and do their work. So, look, if you learned something new, I'd love to hear from you in the comment section. Thanks so much for tuning in today on Dr. Osborne's Zone. Don't forget, we do shows every Tuesday evening, 6 p.m. Central Standard Time. And as well, don't forget that we're here every Thursday, minus holidays, for live Q&A. So if you've got questions that you're burning for an answer and you want to ask me your nutritional questions, hit that subscribe button, hit that bell so that you get notified every Thursday when we go live to answer those questions. Hope you have a fantastic day. We'll see you on the next show. Thanks for tuning in to the Dr. Osborne Zone. Don't forget to share, like, and subscribe for more content like this, and make sure you come back next Tuesday at 6 p.m. Central Standard Time and Thursday at noon 30 for more episodes.